Hello, I'm Dr. Cora Sternberg, and on behalf of CME Outfitters, I'd like to welcome you to one of our CMEO podcasts in the series on castration-sensitive prostate cancer, navigating the current diagnostic and treatment landscape. Today, we're going to talk about sorting out the androgen deprivation therapy options for locally advanced castration-sensitive prostate cancer, and for advanced castration-sensitive prostate cancer a little bit as well. This is brought to you and supported by an educational grant from Astellas and Pfizer. As I mentioned, I'm Dr. Cora Sternberg, the clinical director at the Englander Institute for Precision Medicine and professor of medicine at the Sandra and Weill Mayer Cancer Center at Weill Cornell Medicine in New York, New York. And I'm very honored to be joined today by my dear, dear friend and colleague, Dr. Neil Shore, who is a urologic surgeon, but he's also quite a medical oncologist as far as I'm concerned. He's the medical director at the Carolina Urologic Research Center and the CMO as well of surgery and urology and Genesis Care in the United States. And he works in Myrtle Beach, South Carolina in the United States. And we're very fortunate to have Dr. Shore here with us today. The learning objectives today are: one, to evaluate strategies for the management of locally advanced castration-sensitive prostate cancer, and secondly, to differentiate the potential for adverse effects amongst androgen deprivation therapies. So Neil, I'd like you to start out perhaps by just giving us some background about prostate cancer stage and what we see at initial diagnosis.
Yeah, thanks very much, Cora. I would just like to say thank you for the kind words, and it's a great pleasure to be here with you. You who have such a unique perspective, having spent so much of your career both in Italy, within Europe, and in the United States. So you have a great appreciation for the importance of multidisciplinary care, especially for our patients with highly aggressive and with advanced prostate cancer. As this slide demonstrates, many of our patients who are diagnosed, depending upon the region of the world, in the U.S., we think it's maybe upwards of 80% that have localized disease, but yet another 20+% or more will have regional lymph node metastases, and certainly somewhere now in the U.S., 5 to 10% will have a bona fide metastasis castration-sensitive prostate cancer. Higher in other parts of the world, right? In Eastern Europe, the Middle East, parts of Latin America. And what we know from many really very important meta-analyses and reviews is that the earlier stages, these patients have a better prognostic survival, no doubt about that. The key thing, I think, is that patients who end up with metastases newly diagnosed, there you see that 30% 5-year survival. I think those numbers are getting a little bit better now as we continue to improve our castration-resistant therapeutics, but nonetheless, the clock is ticking, and the clock starts to tick very quickly with obvious bona fide metastases based on conventional imaging, CT scan, and bone scan. And then we have patients who have extracapsular extension, which may be very obvious on digital rectal exam, on CT or MRI. And then some of these patients will have lymph node enlargement within the pelvic rim. And so you see these treatment options that are on the right side of the table. And I think these are the interesting things that we're going to address in our presentation tonight.
Exactly. Thank you. Do you want to talk about the evolution of androgen deprivation therapy?
Yeah, I'd love to. This has been a big part of my career. I really started getting very interested in this in the 80s. Everyone knows the pioneering work of Huggins and Hodges. They got a Nobel Prize for bilateral orchiectomy when they demonstrated that in 1941, patients who had metastatic disease had marked regression of typically of their pain with bone metastases. They got a Nobel Prize in 1966. And bilateral orchiectomy was sort of it for lowering testosterone. In the 80s, when I was in my training, we started to see daily, then monthly administrations of various LHRH agonists, and we saw depot formulations go from 1 month to 3 months to 4 months, 6 months. You see the Histrelin, which is a 12-month implant. And then, somewhere in the mid 1990s, we saw, in really the decade of the 90s, the vintage AR inhibitor drugs, flutamide, bicalutamide, lutamide, and these were the first oral AR antagonists. Bottom line is they were partial antagonists, and at a certain point in time, with administration of the therapy, they actually began to demonstrate agonist effect. By early 2000, at the end of 2009, we saw the approval of degarelix, which is a GnRH antagonist, which has a more direct mechanism of action to inhibit testosterone by directly inhibiting the receptors of the anterior pituitary. In 2011 and then onwards, we see the development of oral, or what some would describe the novel hormonal agents, the AR pathway inhibitors, that have a much more powerful impact on the AR, the androgen receptor, compared to the vintage AR inhibitors. And it began with the development of abiraterone acetate, and that proceeded to enzalutamide, apalutin, darolutamide. What's important to note is enzalutamide currently is the only ARPI that it has the broadest approval. It's approved in post-chemotherapy MCRPC, pre-chemotherapy MCRPC, non-metastatic castration-resistant prostate cancer, and in MCSPC, low and high volume. Abiraterone is approved in MCSPC, low and high volume, and it's not approved in NMCRPC. It does have approval pre and post chemotherapy MCRPC. APA approved in MCSPC and NMCRPC, and Daro only approved in NMCRPC. So we have a little bit of an embarrassment of riches. We have opportunities now to think about lots of different choices. Relugolix, the last name on the list here, just got approved at the very end of 2020. And this is an oral GnRH antagonist, similar in mechanism of action to degarelix, but it's an oral as opposed to a parenteral. So it's not given IM or sub-Q. It's a once-a-day pill. And one of the things that we can, and there's obvious, appeal for some patients who don't like needles. But interestingly, I think the field of cardio-oncology, and you've been really pivotal in this for your career, is, can we distinguish other safety and tolerability features of an antagonist versus an agonist? And one of the things it's very interesting is to think about and understanding the risk of cardiovascular toxicity, especially even in combination with these other agents, and certainly other agents that we use in advanced prostate cancer. So it's a great time for patients and our colleagues.
I think we've been very fortunate to have been involved in all of these trials with abiraterone, enzalutamide, apalutamide, Dara, relugolix. It's been really a very exciting time. I remember the first patients, they were on a placebo or abiraterone, and they would either live or die. We treated the sicker patients in the very beginning, and just to see, you didn't know what arm they were on just how they did, and it was just really amazing what's happened and how things have changed. And I think we've clearly shown we can improve survival in many different disease states with these different drugs, which has really been quite incredible. So we use androgen deprivation therapy in many different disease stages. Perhaps you'd like to go through, when we use it in the early stages and when we use it for locally advanced and how long, and for those with metastatic disease that are hormone sensitive.
Yeah, thank you. This slide is kind of giving somewhat of an overview. It's not completely exhaustive, but what we know, as a basic caveat is, lowering a man's testosterone level is no free lunch, right? And so we don't want to consider androgen deprivation therapy unless there's level 1 evidence to support its use. The first bullet for patients who are T1, T2, who are going to either undergo surveillance or an active intervention, radiation, surgery, maybe some folks who are intrigued and involved with focal therapy. We don't have level 1 evidence right now for T suppression. But when we have some patients who have locally advanced prostate cancer, there can be clearly benefit for patients who have intermediate, high, or very high risk who are considering radiation as an option. With the intermediate risk patients, there's ample data to support ADT for a course of 4 to 6 months. We have numerous studies supporting 18 months to 3 years of ADT for patients undergoing radiation therapy. We don't have definitive evidence for using ADT in neoadjuvant or adjuvant therapy for radical prostatectomy, but there are a whole series of really intriguing studies that are combining ADT both with neoadjuvant and adjuvant and adding the novel hormonal androgen receptor pathway inhibitor. So that's something we're always trying to improve upon, because our patients with high risk disease who undergo primary interventional treatment with RT or RP still have a pretty high percentage of failure. So that's still an important goal. And lastly, of course, metastatic disease, where it started with Huggins and Hodges back in the 1940s, is we always say, it's the gold standard, the mainstay, it's foundational for all of these patients. The really big question now is, it's been ADT monotherapy for our newly diagnosed MCSPC patients, or even our recurrent MCSPC metastatic, recurrent meaning those who may have had surgery or radiation, get lost to follow-up, come back to your clinic, maybe they move from New York to Italy and show up, and now they have metastatic disease and they have eugonadal levels of testosterone. So the question is, for that group, is monotherapy ADT still adequate? And I think we have this in here somewhat rhetorically to say it clearly is not. There's so much level 1 evidence for combination therapy, and I think we want to talk about that.
Well, I think, I agree with you on your last point, actually on all your points, but in Europe, it's harder. And I don't know exactly the status in every country, but when the country, it's also, you're talking about reimbursement as well. But clearly in the United States, monotherapy is not considered adequate when you're starting somebody with metastatic disease with just ADT alone. And ADT is used either with one of the novel hormonal agents or with chemotherapy. And we even heard recently at the just recent ASCO from the Peace 1 study that perhaps we should be using both chemotherapy and hormonal therapy in patients with hormone-sensitive disease. So I think we'll have to see further about that. When I think about locally advanced disease, I agree also with everything you've said. And I think that there have also been a lot of advances in the technology in terms of the radiation technology and the radiation machines and the way that they can MRI target what we're doing. I mean, the first studies that we did where we were giving people 3 years of therapy within the BOLA studies back in the URTC, I would say that the radiation therapy was not as sophisticated as it is today. And I don't think many people still give 3 years of ADT. In any case, it's usually somewhere like 18 months or 2 years. Do you use Decipher tests at all to decide on how long to give ADT or as part of a study?
We do. We're involved in those studies. I think that is a really good test to try to understand, does a patient need any ADT, or can we get away without using it, or can we shorten that duration? I agree with you. I try to reduce it. I rarely give anybody 3 years based upon the BOLA data, and I think most of us would like to go to somewhere between 12 and 24 months, depending upon how patients are tolerating therapy. I agree with you in your first point. Accessibility is so important, and regional, global disparities of accessibility is something that you and I and some of the really wonderful conferences that are internationally focused, like the Advanced Prostate Cancer Consensus Conference, we're addressing, full on the importance of these disparities. And the thing about prostate cancer is it doesn't discriminate whether you're in Asia, Africa, or North America. We want our patients to be able to get the best treatments.
I agree with you. The Americans are often offered, at my experience, the best treatments, but they can't always afford it, and the prices are quite high. But anyway, let's see. This slide is about the duration of ADT when radiotherapy is debated. I think we discussed a little bit about this already. Is there anything more to say about this?
Yeah, I think you're absolutely right. I think we did kind of hit on it. I think it's nice to see the references here for the audience. We're talking about the 4 to 6 months of ADT for our patients undergoing quality external beam radiation therapy. Your point's really well taken. The improvements and the guidance and the ability to avoid collateral damage to the bladder and the rectum is really improved for our radiation oncology colleagues. And then, of course, even patients who are high risk to very high risk, if we can cut down on that level of toxicity from the T suppression, I think that's a very nice thing. And there's just a breakdown here between the duration of ADT versus no ADT between different grade groups. A little a pitch. I love the International Society of Uropathology grade group system, the 1, 2, 3, 4, 5, as you see listed here. I think it's really helpful to discuss with a patient and say, you're grade group 1, 2, you're potentially a very good candidate for active surveillance. You have 3, 4, 5, in particular, if you're a 4 or 5, you need more aggressive treatment. So, that's just, I think, has been a nice advance. But I think this summarizes our discussion we just had.
Absolutely. So I don't know if you want to discuss anything about the mechanism of action of androgen deprivation therapy. Maybe we've sort of discussed this already too as well.
I think we did. I mean, agonists have been around now for close to 40 years. I think the antagonists, the degarelix was a little bit of a challenge because it was monthly. There were some injection site reactions. But to my way of thinking, an antagonist is just very obviously a better mechanism of action. You don't get any testosterone surge and no risk of clinical flare. You can try to abate that with the earlier generation AR inhibitors, but frankly, if you have MCSPC, I think the data is overwhelming that you begin with a novel hormonal agent such as Enza or APA or ABI in conjunction with ADT. One sees the mechanisms of action listed here. 5AR, these are, again, generic drugs that are all approved, whether it's finasteride or dutasteride, for gland volume reduction for patients who have BPH and lower urinary tract symptoms. But there, frankly, is no level 1 evidence for their use in prostate cancer. But I think in the real world, some folks use it periodically. You can see PSA declines, but there's no defined role for it in prostate cancer today.
Agree. So I think what we're talking about essentially is balancing the benefits and the harms of ADT as well. I think that we need to discuss that well. I mean, maybe you'd like to start out and say something about that.
Yeah, there's probably no other, I'm not aware of any other solid tumor that has such a exquisitely sensitive effect from hormone depletion. We see it to some degree in breast cancer, but it's just overwhelmingly positive in prostate cancer when you deplete testosterone levels, and then subsequently, which the role for that is T and DHT as ligands to the androgen receptor and translocation and cellular proliferation in the nucleus, and then additionally the oral AR inhibitors, which further competitively impede with the AR. So we're sort of going from androgen deprivation to an attempt at androgen receptor axis annihilation. We see response rates overwhelmingly so in CSPC when we lower the testosterone level, and we see PSAs decline. And so I think many of our colleagues say, great, I declare victory. The PSA went down. Maybe I see objective responses on imaging, but we have a lot of data that we're going to review that says, wait, you can do better. But having said that, when you drop a man's testosterone from the eugonadal range to the castration range of 50 nanogram per deciliter or less, you're essentially, in addition to causing a loss of sexual function, hot flashes, you're causing bone demineralization, you're potentially augmenting cardiovascular complications and neuro-oncologic complications of depression, and even some cognition. It's a little bit, there's a debate about that, and we've seen studies pro and con regarding its effects on long-term risk of dementia. But there's just no doubt, in addition to the gynecomastia and the central obesity that men develop and the visceral adiposity, there's real side effects. But having said that, that's the challenge we have as medical oncologists and urologists and radiation oncologists is, how do we, balance these things with these side effects? And I think that's really still a big part of the art of medicine, unless there's clear level 1 evidence that somebody who has a reasonable actuarial survival and your goal is prolonging survival and preserving quality of life and preventing complications of therapy, how do you pick? And that's still, to me, is really great about, the ability and the honor to take care of these patients.
And I think that there are starting to be trials more and more where people are trying to do anything to avoid the androgen deprivation therapy because of the side effects. But thus far, it has been, without a doubt, the most successful. The testosterone surge and the flare is something that we don't really see it anymore because we take care of that, correct?
Well, I think the surge can be silent, right? I mean, you see these super physiologic surges in testosterone over the course of the first, couple of weeks that you don't see with an antagonist. And, it's always been intriguing to me to think, what are that biochemical surge? What are the long-term implications of that? And that's still a really a hotbed of controversy to discuss. There's no doubt that patients who have significant bone metastases are at risk for pain exacerbation and or a cord compression if they have a lot of vertebral body metastases. Patients who have bulky localized disease in the prostate and even maybe sometimes not so bulky may have worsening of their lower urinary tract symptoms and maybe even at risk for infection as well. And then, of course, the very rare bulky retroperitoneal adenopathy that can cause ureteral obstruction. So I think these things can happen. A lot of it depends upon where you're practicing and the kind of population you see and the tumor burden, the extent of disease. For locally advanced disease, I think it can have an impact on, avoiding symptoms, as I mentioned. So I think we covered this. Look, the agonists have been around a long time, but, to my way of thinking, the antagonists are a superior mechanism of action. They do what you want to do from the beginning, right? I mean, the goal of ADT is to lower testosterone, not to increase it. And we want to do it, it causes these side effects we discussed. And a real area of interest to me is the cardio-oncologic effects. We see persistent FSH declines in patients who are on antagonists as opposed to agonists. And there's a lot of research looking at what does that mean in terms of its impact on atheromatous plaque and coronary vessels. What's the effect on cardiac myocytes? And I think these are areas and areas of research that have come forward in trials that I was proud to be part of, such as the HERO trial that led to the approval of relugolix. And we have other data that's coming out. And so I think we're always challenging ourselves to figure how can we give the best therapy to somebody despite the fact that there are known effects.
I can tell you that at Cornell, we start everyone on the antagonist daguerreolex, and then after a few times that they receive daguerreolex, we switch them over to Eligard or the Lupron or one of those other drugs, because of the more ease of administration of an every 3-month drug rather than an every 1 month subcutaneous drug. That's the way it's been. When I worked in Italy, we were always giving the drugs to the patients that they would be able to actually take it home for a whole year, and they would start out with 2 weeks of a blockade with perhaps bicalutamide, and then start something like an LHRH agonist. What's interesting to me is I see some of the radiation protocols that are coming out that are national protocols where they just start out with an LHRH agonist with no 2 weeks or 1 month blockade with a bicalutamide, and I've never done that before, and it's a little bit frightening to me. But I suppose if these are not patients with vertebral metastases or risk for spinal cord compression, it may not be as risky. But as you said, if they could have locally advanced disease, that could be questionable as well. So here, I think you mentioned many of these side effects of ADT. Are there any here that we haven't mentioned?
No, I think we covered them. I do think for our colleagues, it's not enough to just say to a patient, well, you're going to get some sexual dysfunction. You may have some hot flashes. We've got to be thinking in the totality of the patient. Their cardio-oncologic effects, if they've had a prior major adverse cardiovascular event such as an MI or a CV, a CVA. If they have, dyslipidemia or hypercholesterolemia issues, if they're diabetic. But I think we have a lot of strategies, right, to help with the fatigue. Exercise is so important. Directed exercise is incredibly important. I like to recommend a low carbohydrate or a heart healthy diet. And no matter how old my patients are, I try to get them involving some sort of, weight training and cardiac event. Frankly, cardiac aerobic exercise is really what I meant to say. This is really true for everybody, but it's even more true for some men who you're lowering their testosterone levels on. And I've become so much more aware of the fracture risk. We used to say, nobody really gets fractures, and because we weren't looking at it. It was our orthopedic colleagues who were seeing these fractures, much like our cardiology colleagues are seeing the MIs today. So we need to be more well-rounded. We need to invoke multidisciplinary team support.
We need to evaluate bone density for sure and have our patients on supplemental calcium, vitamin D. And I absolutely agree with everything you've said about exercise. It's so, so important. It's one of the major things that we must do. The cardiovascular side effects are perhaps the most frightening to most men who are on these agents. You want to go through this a little bit? Because I know you've become quite an expert on this topic.
Yeah, well, thank you. I mean, think about it right now. Number one, I think it was in 2012, there's a boxed warning for all of the LHRH agonists by the FDA, not the antagonists, but just the agonists regarding their potential for extending the QT interval and really having a good understanding of their risk for cardiovascular side effects. When you look at patients receiving an agonist, this was a study that was done. You see it's referenced at the bottom, but there's an increased risk for patients with the listing here. But just in and of itself, our patients who we start on ADT, they're elderly. That right there is a risk. They're elderly males. They have risk of cardiovascular risk. Many of them are already obese based upon BMI. Many of them already have significant diabetes. That's another risk. Many of them are smokers. Many of them are sedentary. Many of them have other issues such as some of the medications that they take. So in patients who have these pre-existing disorders, the risk of events was certainly significant for patients who take T suppression, but in this study it was lower with an antagonist than an agonist, and that's been correlated with other nice papers by Albertson, who did a really nice review of 6 different studies that was published in European Urology in 2014. Our HERO trial that we presented, published in New England Journal, had similar findings of less major adverse cardiovascular events of what we call MACE with the oral relugolix versus the 3-month leuprolide. And it's interesting to note that more patients will die who have advanced prostate cancer will die of a cardiovascular event than they will of, euphemistically say, Cora, we're in a race with our cardiology colleagues. We don't want our patients with metastatic disease to die of the cancer. Our cardiology colleagues don't want them to die of a cardiovascular event. So that is sort of the corollary goal. We want our patients to do as well as they can, as long as they can. Stay out of the hospital system, stay out of the emergency departments.
Absolutely. People are very afraid of the neurocognitive side effects of ADT as well, too. And there's a lot that's been written about this. And some people just feel like they're moody or foggy or depressed. And some people just absolutely will not stay on ADT because of that as well. And they're frightened about it. What's your experience been in terms of that?
Yeah, it's so fascinating, right? I mean, you'll put some men on T suppression therapy, ADT, and they come back in, they're like, yeah, God, now I feel fine. Now it's all good. And then you'll have some patients who are just absolutely miserable. They can't get off the couch. They're having hot flashes. They're depressed. I've seen some with some really significant depression. And then, it ranges. There's a whole spectrum. I've had patients who say, yeah, I'm fuzzy. I can't. I can't do puzzles the way I used to. I can't even do my basic arithmetic the way I used to. So I think there's so much we're learning from a neurocognitive, neuro-oncological capacity, doing more and more tests to better understand who is at risk for neurocognitive impairment. And, we're looking at some new imaging technologies in terms of blood-brain barrier effects, blood flow in the cerebral blood flow. And then also just, if we could come up with a marker, but I'm not aware of that, but we're looking at that. These are some very nice studies that are published at the bottom of this slide, but, it's been controversial regarding, the impact. Some studies suggesting this may predispose to dementia, and clearly others that are saying absolutely not. They're complicated and challenging studies to do. Suffice it to say, keeping somebody, I think, very engaged in life, very engaged in using all of their, mental capacities to the best that they can is right now my current strategy. But I'm fascinated by this. And because of this, I don't pull the trigger for T suppression anywhere as lightly as I did in the earlier part of my career.
I don't either. And I personally am a great believer in intermittent therapy as well, especially in those patients who are suffering. A lot of our patients are elderly, so they're starting off already having some cognitive problems. And then if you keep them on constant T suppression, it can be a problem. So I personally, when I can, I'm a believer in intermittent therapy. You wanted to talk something about the major adverse cardio events. I think we've talked quite about this. This is from your HERO trial, right?
It is, and we did talk about it, but this really kind of just demonstrates one of the things we did is we excluded patients who had a major adverse cardiovascular event in 6 months prior to their getting enrolled in the study at baseline. And then these were patients who were randomized in a 2-to-1 fashion who had either metastatic disease, locally advanced disease, or just were not suitable for primary interventional therapy and were deemed appropriate for ADT. And they were randomized 2-to-1, relugolix, 3 pills the first day, 1 pill per day after that, versus Q3-month LHRH agonist. And so in both arms, about 15% of the patients had a MACE 6 months further out from beginning. I think a lot of studies now would say that certainly in North America, your baseline might be 30% or higher of patients who have MACE when we initiate an ADT. But having said that, we try to remove as many of those patients as possible. And then even with that, what we saw here was in the all-comers in this group, there was a markedly increased risk of a MACE in the leuprolide group versus the relugolix group, as you see very clearly demonstrated in the graph to the right. The curves separate very early. MACE was a secondary endpoint. The events were adjudicated by the local sites. We didn't have central adjudication, but it clearly is the separation of the curves here favoring the benefit of the antagonist over the agonist. So I think this was very compelling. This adds to the body of literature that we were talking about earlier. You mentioned one thing I just wanted to say too about intermittent therapy. I don't know that we have a slide on it, but we did a subset of about 184 patients in the HERO trial who's at the end of 48 weeks stopped both their LHRH agonist and the relugolix one pill daily. And over 50% of the patients by 90 days were back to eugonadal testosterone levels with the relugolix once a day pill, and only 3% in the LHRH. So, one can see that marked difference in T recovery. And I think that's really important for patients who are just pretty miserable on T suppression.
Yeah, I remember from the old BOLA trials where we had patients on, that were elderly patients, they were on for 3 years. And after we looked at the testosterone suppression, some remained suppressed up to 5 years afterwards. So, I mean, if these were elderly patients that were on long-term LHRH agonists, that's what can happen. That's one of the reasons why I've always believed in intermittent, if it's possible, especially in those patients who are suffering. And I think that this is an important breakthrough here. Do you plan to look at overall survival data here? It's not one of the major endpoints.
Yeah, we are. We have a lot of other studies that we're doing here. Important studies of combining relugolix. We had a nice ASCO GU presentation. Dan George was first author, combining enzalutamide with relugolix, demonstrating safety and tolerability. Relugolix with docetaxel, relugolix with radiation. We have ongoing studies looking at combining it with apalutamide and also darolutamide and abiraterone. So we want to make sure that this is an opportunity for all combinations.
Important to see that there's not competition, or that one drug doesn't lower the effects of the other drug or make one or the other more toxic. So I think that people are waiting for those kind of studies as well. And probably there'll be studies in combination with radiation as well, I would imagine, in more localized disease. This talks about compliance, cost, accessibility. I think there's a lot on this slide. I don't know if we want to go through all of this.
Yeah, I think one of the things that I've heard, some of our colleagues say as well, I'm so comfortable with a depot formulation of a 3-month, a 4-month, 6-month, even arguably a 12-month. I don't know that my patient will take a pill. And, I think that's sort of interesting because, look, we give patients, 2 pills or 4 pills or 4 capsules, sometimes with food, without food, sometimes needing a concomitant steroid. We do this in our advanced prostate cancer patients. We certainly do this in our advanced kidney cancer patients. We do this in breast cancer patients. I think in my estimation, when patients know they're taking a medication, a pill for their survival, just like they do for their elevated blood pressure or their dyslipidemia or hypercholesterolemia or diabetes, they take the pill. And I think a lot of it is nursing and patient education. I know that parenteral drugs have been with us for decades, but I don't really buy the concept that, well, they'll only, they won't take it. I see the orals as being very advantageous when our patients are geographically disadvantaged from coming into clinic. And frankly, what better time to have had an oral medication to lower testosterone than during a pandemic when getting into a clinic was a challenge.
People were afraid to go to clinic. You're right. You are so right. And Americans are really used to taking pills. Even more, it's more culturally habitual to use pills than injections than in Europe, where they're less likely to take pills. So I don't think in the United States this should be a problem at all. And then we'll see how it goes out in the rest of the world. But Americans are very used to taking pills, I would say. I agree with you on that. So I think we're coming to an end, and Dr. Shore has given us some brilliant insights into hormonal therapy for patients with castration-sensitive prostate cancer, both those with locally advanced disease and patients with metastatic disease. They usually require androgen deprivation therapy. We should consider multiple there's a multitude of factors when we give our patients androgen deprivation therapy, and we need to think of their quality of life and to optimize their the patient benefit. But quality of life is very important. We didn't talk a lot about cost, but I think that those are other factors that probably will factor into our decisions. We need to consider the mechanism of action, the administration, the drug-drug interactions, and we're going to be learning more and more about that with the oral drugs, the safety and the adherence for the choice of ADT. But ADT still remains the fundamental therapy since the original work of Huggins back in 1941, some 80 years ago. And I think on his anniversary, we can still salute that finding that he found that ADT would help cure prostate cancer, or at least cure it for a certain amount of time. And I want to thank Dr. Shore very much for his wonderful, wonderful talk today. So this has been a CME activity. So in order to receive credits or CME points for this activity, the participants must complete the post-test and evaluation online. Just go to the evaluations tab and click on the link to complete the process and print your certificate. So thank you very much. And there are 4 episodes of this podcast, and we hope you'll be able to listen to all of them. Thank you very much. And thank you to Dr. Shore.
Thank you.